Assalamualaikum and good afternoon. Today I'm going to talk about regional anesthesia in trauma. So this one going to be my outline of presentation. First, little bit of introduction. I divided into upper limb, lower limb, thoracic, and new collaboration is a new collaboration that we did with the ED department. For introduction, regional block may offer many ideal analgesic advantages include superior anesthesia, stop the stress response, increase alertness, patient cooperation, and avoidance of systemic side effect. Therefore, it also facilitating ease of transport and chronic pain protection. Avoidance of general anesthesia may avert iatrogenic risk of airway instrumentation and positive pressure ventilation, such as difficult intubation, aggravation of cervical spine injury, and pneumothorax enlargement. As we all know, the most common approach to pain management for trauma is intravenous opioid. While opioids are excellent analgesic, it's work quick, but there are some adverse effects, which include respiratory depression, vasodilatation, and hypotension, especially in patients with hypovolemia, can cause delirium, commonly nausea and vomiting, constipation, pruritus, and also increased length of stay in emergency department or recovery room. So regional anesthesia using single injection technique and continuous peripheral catheter play a valuable role in multimodal approach to pain management in trauma patient in ICU. This was mentioned by Schultz and colleague in 2005. Okay, what are the advantages of regional anesthesia? First, it can decrease adverse effect compared to some conscious sedation technique. It can prevent hypoxia, agitation, nausea, or vomiting. It also can decrease need of sedative and improve neurologic assessment. Thirdly, reduction in opiate requirement. It also can reduce the length of stay in emergency or critical care unit. It can improve comfort and safety for transport. Decrease need of staffing, secondary to decreased need for monitoring compared to procedural sedation. It can reduce the stress, respond to injury, decrease cost compared with conscious sedation. Lastly, it is related to the monitoring and staffing costs. History of RA in managing combat injury was first described in the Vietnam War. Overall, about 644 regional anesthesia procedures were performed, including 361 perineural catheters, which the mean catheter infusion duration was around 9 days. Okay, what about single shot versus catheter? For the trauma, we suggest normally it's a single shot due to infection. Because when you use a indwelling catheter, it can lead to infection, whereby the infection rate was said to be about 4 to 5 times higher as compared to single shot. It's due to that the area that we are giving the block is not really sterile as compared when we did the block in the ICU or in the OT. So we go to the trauma to the upper limbs. So Rogers and colleague mentioned that although surgical intervention for multiple trauma more frequently require GA, regional anesthesia should be considered in patients with an isolated orthopedic injury or even in burn patient. Blaves and colleague reported excellent analgesia, avoiding intravenous sedation after interscalene block in the ED department for treating shoulder dislocation. Supraclavicular block in patients with upper extremity fractures, dislocation, experience a shorter length of stay without any impact in patient safety or satisfaction. So what are the indications of regional anesthesia for the trauma? It's either we use for analgesia or for anesthesia. So we divided into the region. So for the upper limb, shoulder, humerus, elbow, forearm and wrist, and also hand and fingers. So if you talk about regional anesthesia, you must flashback about the brachial plexus. So for the shoulder, normally we have to give interscalene block. For the proximal humerus, also interscalene. For the mid and distal humerus, we can use the supraclavicular that cover the trunk. For the elbow, also we can use supraclavicular or infraclavicular, whereas for the forearm and wrist and hands, we can use axillary or infraclavicular. Alright, this diagram show the same. Okay, for the clavicle, however, we cannot give in block because the proximal clavicle is not covered by our block. So we can only give mid and distal. Therefore, for the clavicle fracture, we can give the analgesia. Okay, again, shoulder interscalene. Okay, this one the repetition. Alright, we go for the lower limb blocks. RA was associated with better outcome than GA in terms of mortality, delirium, intensive care unit admission, and ventilator care in elderly patients who underwent hip and fracture surgery. Okay, Dr. Mayer demonstrated the importance of peripheral nerve block for prolonged pain management and repeated surgical intervention by placement of continuous lumbar plexus and sciatic nerve catheter in soldier shortly after sustaining lower extremity injury. A single injection femoral block performed at the scene in elderly patient with knee pain after trauma has been shown to provide effective analgesia and facilitate transport. The acute pain with femoral fracture is excruciating and one of the more painful fracture. So lumbar fracture is common and associated with severe pain and often neglected in ED. So what are the benefits of regional? The benefit of giving regional anesthesia is we have a better pain control. We can reduce the incidence of deep vein thrombosis, decrease post-op confusion, especially in the elderly, and reduce incidence of post-op pneumonia. So what are common injuries in trauma? So we have a hip fracture, we have a neck femur fracture, patella fracture, tibia fibula, and also foot fracture. For the hip fracture, we can give Peng or Fakhzan block. Whereas for the neck or femur fracture, again, we can use either Fakhzan or Peng. For the femur fracture, we must use Fakhzan block. For the patella fracture, you can use either femoral or adductor canal block. For the tibia fibula, we can use sciatic plus femoral. And for the foot, you can use popliteal or popliteal sciatic approach. So let's go about the Peng block. It's a novel block for the hip. It's a most recently block for the lower limb, was introduced in 2018. It's more complete analgesia to the hip because it covers branches of femoral, accessory obturator nerve, and also obturator nerve. And why is it popular? Because it also have the muscle sparing effect. So Peng cover anterior capsule of the hip joint, some extension to the obturator nerve. They are effective for femoral neck fracture, intertrochanteric fracture, pubic ramus fracture, acetabular fracture, and also hip dislocation. However, the nerve fiber do not extend beyond intertrochanteric line. Therefore, fracture of femur beyond this point will not be adequately anesthetized. So you might need to have another block, such as femoral block or Fakhzan block, to have a full block for the area of fracture. So roughly how to do it, patient in the supine position, we use a curvilinear probe. Okay, so we put the probe perpendicular and our aim is to see the femoral artery, okay, anteroinferior iliac spine and internal pubic rami. So our aim is to give the local anesthesia is around here. Alright, how much to give is around 20 to 30 mils of local anesthetic. So normally we use, you can use either 0.375 naropin or 0.5 naropin. Right, next we go for thoracic block for trauma. Pain impair respiratory mechanic, predisposing to atelectasis, secretion irritation, and pneumonia. Rib fracture are the most common injury associated with chest trauma, with incidence about 25% of all trauma admission. Blunt thoracic injury, such as rib fractures and pulmonary contusion, are common with significant morbidity and mortality. as we know, pain impaired respiratory mechanic, predisposing to atelectasis and later pneumonia. 25% of annual traumatic death result from chest trauma. So rib fracture are very painful and limit the patient's ability to breathe deeply. This shallow breathing and lack of deep inspiratory sigh promote atelectasis, VQ mismatching, and hypoxemia, leading to pneumonia and respiratory failure. The goal of therapy should be minimize respiratory depression and optimize respiratory excursion. Why? Minimizing possible side effect or complication of the technical procedure, such as local anesthetic toxicity or iatrogenic pneumothorax. So what are the mode of regional anesthesia available? There are few. For example, thoracic epidural, we have paravertebral block, we have intercostal nerve block, we have serratus anterior block, and we have erector spinal block. Thoracic epidural used to be the gold standard for the management of the rib fracture. However, now with the paravertebral and also serratus anterior plane and erector spinal block, we can provide good analgesia for the rib fracture. So this diagram shows the different side of the block. For example, the intercostal nerve block is blocked around here, more lateral, and then for the thoracic epidural is direct to and erector spinal block, we block at the erector spinae. So our aim is the local anesthetic will go flow into the nerve. So for the thoracic, I will talk a bit about erector spinal block. Mauricio Ferro in 2016 described the erector spinal block. Okay. LA is injected into deep erector spinal muscle on the top of transverse process. Block work at the origin of spinal nerve based on the cadaveric and contrast study. The LA is deposited near costotransverse foraminal. It will spread to either dorsal ramus or ventral ramus. It also spread longitudinally to the tissue complex. Alright. Some studies suggest that anterior diffusion of the local anesthetic into the paravertebral space also occur. Okay, so this tip of transverse forceps, we give our local injection here. So the LA will spread either to this way, alright, or direct way to the ventral ramus in the intercostal nerve, right? Okay, we can do the erector spinal either while patient is sitting in the supine position or at the lateral position. Okay, this show patient in the sitting position where we can see three muscle layer, trapezius, rhomboid, and erector spinal muscle. This is a transverse process. So our aim is to give a local anesthetic at the between transverse process and erector spinal. Alright, so we use a linear probe. We scan from the lateral to medial. So from lateral we can see this is a ribs and this is a pleura. So we go medially to, we can see the costotransverse ligament, right? This is costotransverse ligament. This is around the T5 sagittal. We go further until we see the transverse process, right? So how to differentiate between transverse process and ribs, whereby the transverse process is more flattened as compared to the rib, and also we are difficult to see the pleura. So here is the transverse process. So if you go further lateral, you can see the lamina. Alright, this is the lamina. Okay, so our aim is to give the local anesthetic at the transverse process, right? Okay, transverse process, we deploy our local anesthetic. Right? Why you use can you deploy here? Yes, you can also deploy here, but it's a safety measure. You can better to deploy at the tip of the transverse process. So that say you overshoot, you will hit the bone rather than you go deeper into the pleura. Alright, this show the local anesthetic is being delivered, right? So, cadaveric study show 20 to 30 mils of injected spray of mean 4 to 5 intercostal spaces craniocaudally. One case report block activa level is sufficiently have multi-dermatomal sensory block ranging from T1 to L2. Okay, now we talk about new paradigm. Since December 2020, we had a collaboration with the HKL ED department to extend our regional anesthesia service for the trauma to patients in the emergency department. Since then, if there is a case that requires block, the regional team will come to assist the ED to perform the block. The service currently only limited to office hours during the working days. The aim is to teach the ED team to perform the block and to improve the regional block services to the patient. Okay, up to the August this year, is about 100 patients was given regional block in the emergency department. It is due to the fact that now we have increased cases of the COVID. So the regional anesthesia was not given so much as compared to the earlier months, like say during the first 3 months, like January to March. Okay, what block we usually give? We usually give for the shoulder dislocation, we give before the CMR, and also for the pain relief, either for the multiple rib fracture, for the fracture of femur, hip, tibia, radius or ulna, or even of chronic pain. So this is type of block that we are given in the ED. So for the upper limb, we are given interscalene, supraclavicular, infraclavicular, and axillary. For the lower limb, we give sciatica, Peng, sciatic, femoral, or adductor canal. And for the truncal, we have serratus anterior, erector spinae, and also pecs. So from this chart, we can see about interscalene, we have given 14 cases. Mostly interscalene we given for the shoulder dislocation cases. For the supraclavicular, there is 23 patients. Normally for the CMR for the radius or ulnar fracture. For the infraclavicular, okay, we have given 1 cases, and also for auxiliaries for normally for the fracture at the hand area. For the lower limb, so most of lower limb we give a sciatic nerve block. Okay, so followed by femoral about 25%, Peng about 6%, and at the canal about 17%, and bursa iliaca is about 10% of the patient. For the truncal block, okay, most of the block we given is erector spinae because most of them refer actually for the multiple rib fracture. We also give about 3 cases of serratus anterior block, okay, and also 1 case for the pec block. Okay, this is my references, and with that, I thank you.